to medical students that are understanding anatomy. As I alluded to before, is that, as a registrar, once you're trying to understand or read about the ventilation of the middle ear, you understanding or seeing the structures of the middle ear really makes you comprehend what the ventilation is about. And as you can see here, the main ventilation pathway in dark blue is coming from the Eustachian tube, going through the isthmus that is between the cochleariform process and the stapes, going into the mastoid air cell system. There's obviously an alternative pathway and an ulterior pathway as well that is through the tensor fold if that tensor fold is absent.
No,
Talking a bit about imaging when it comes to endoscopic ear surgery is that the best views are usually attained when we reconstruct our planes to the external auditory canal, mimicking our angle that we project our endoscope inside the ear, so that we will anticipate what we encounter when we go in.
Yeah.
When we talk about endoscopic specifications and configuration of the endoscope and the cameras, there are various lengths and diameters of the lens and angulations of the lens, but the majority of ear surgery is using a 14 to 18 centimeter long, 4 millimeter diameter, 0-degree Hopkins rod. This, as we may have noticed just by the definition of it, is that this is the same endoscope that we use for sinus surgery. And this has, as I'll talk about a bit later, bearings to do with cost. So the advantage of using this particular endoscope, a longer and a wider endoscope that is that it offers a wider field of view. And secondly, the surgeon's hands are quite far away from the external ear canal, and hence they're less likely to interfere with one another as the other hand is holding another instrument. So although using a high quality Hopkins rod is essential, the digital camera that is attached to the endoscope also matters when it regards to the quality of what you see on your image. And what is best in the market that is available now is what they call 3 charged coupled devices. So that's CCDs, where each one takes a separate measurement of the primary colors in each pixel. So each pixel will have a red, green, or blue light. But if you compare that to the single CCD cameras, they only detect about 1/3 of that color information for each pixel. So the disadvantage of this, for example, is that if you are with the endoscope in tight areas that are prone to bleeding, for example, you immediately get a red out. And that obviously is something that you do not want. Moving on to some diagnostic uses of the endoscope. If we look at uses in the outpatient department on otological examination, serial photo documentation is possible, and it's especially relevant in retraction pockets over a follow-up period that help us to decide whether we're going to undertake or continue to undertake a conservative approach, or whether we're going to go in and do something a little different. And the advantage here, the example here that I've given is one that you see in the outpatient department and has a small dimple in the attic on the first image that I've shown there. And with time, you follow up these patients, you document these patients with photographs, and you can see here the subsequent images now has some erosion of the scutum that might tell you to perhaps do something surgically. Secondly, there's some sneak peeks when it comes to diagnosis that the endoscope is used in. The first is the evaluation of the ossicular chain that may be undertaken through an existing tympanic membrane perforation. And this has been studied and performed in an outpatient setting just with the application of local anesthesia. Thirdly, the diagnosis of idiopathic perilymphatic fistulas as well, using small diameter endoscopes through a myringotomy. And in this particular study, once they diagnosed these fistulas, they went on to close the fistulas with some fascia and fibrin glue after elevating a tympanomeatal flap under local anesthesia. And lastly, when it comes to diagnosis, what is also in the literature is that some people do a micro myringotomy with a a 2 millimeter laser assisted device. And that basically allows us to assess the vesicular chain. And in cases in which you suspect otosclerosis, also just to confirm that so that you have a solid plan moving into surgery. The next part of this is, I've talked about diagnostic uses. The next part of this is therapeutic uses of the endoscope. And what is widely done now when it comes to the endoscope is use of grommets, myringotomies, myringoplasties, tympanoplasties, ossiculoplasties are quite widely done now with the endoscope. But what I wanted to turn your attention to when it comes to using the endoscope in our context is this study on improving access to hearing care services and professionals in Malawi. And just to give us a bit of a background, and you'll see where I'm heading shortly now, is that in Malawi, for example, there are only 2 ENTs for a population of about 19 million people. And what they underwent was to share the load of the hearing burden that they have there. So there are 2 types of personnel that, apart from ENT surgeons, they're medical assistants who undergo 3 years of training after leaving high school and receive a diploma in clinical medicine. And there are also ENT-specific clinical officers who thereafter receive about a year and a half of ENT training and are thereafter awarded a diploma in ENT. They were then given this endoscopic configuration that comprised of a mobile camera, a light source, and a screen unit that costed anywhere from about $1 to about $2,000 US. And then they were tasked with the responsibility to perform some endoscopic myringotomies. And as you can see there, that 72% in the study of the cases that they had of the myringoplasties that they performed were actually done by ENT clinical officers. And as you can see here, on follow-up at 3 months, only 30 out of the 60 patients that were done by the clinical officers came at 3 months, but 97% of those cases that were performed by the clinical officers, the grafts were intact. And this kind of rate compares to anywhere else around the world. And just to mention, this effort on task sharing, especially in context that we come from, really is something that we require in the continent that we live in. There are 50 million perforated eardrums in Africa, and this figure is based on WHO's estimate of about 4% of the population suffering from chronic ear disease. And really, we need to think about innovative ways to address this important problem. The second use when it comes to therapeutics with the use of the endoscope, it really imparts us the ability to see around corners. And this is especially relevant in retraction pocket surgery. One of the biggest fears of retraction pocket surgery, especially if you have a grade 3 or grade 4 retraction, is that you inadvertently may leave some epithelium behind when you're lifting up the tympanic membrane. And the use of the endoscope, whether primarily or secondarily in complement to the microscope, allows you to just confirm in different places that you're not leaving any squames behind. Thirdly, minimally invasive second look combined approach tympanoplasty. The use of the endoscope has also given some advantages. And just to give us a bit of a background in this is that second look surgery to check for residual or recurrent cholesteatoma is common practice in parts of the world after canal wall up mastoidectomy, as the rate of recidivism is reported to be far higher than canal wall down mastoidectomies. And that rate can vary between about 10 to about 43%. And one of the main reasons for this high rate of recidivism is poor access, particularly to subsites that include the sinus tympani, the anterior epitympanum. And so the use of the endoscope in these areas showed that you can reduce the rate of residual disease. And that rate reduced from 47% right down to about 5% with the routine use of otoendoscopy at primary surgery. moving forward on the same light is it can be used as a minimally invasive approach to perform second look procedures. And as you can see here, once you want to check for recurrences or recidivism, one can make a 1 centimeter stab incision just anterior to your original postauricular incision in the sulcus. That allows a small diameter endoscope that is inserted through there just to check for residual disease. And this approach or this technique has been verified by performing conventional second look mastoidectomy procedures with the microscope on the same group of patients. And the results in both techniques were similar. But the advantage, obviously, with a minimally invasive technique was that you minimize time and you minimize morbidity. You don't have to reopen the original incision as well. However, there are factors that may require reopening of the original PA incision, and that may include excessive bleeding, extensive recurrence that you may have diagnosed at that time, reossification over the mastoidectomy site, scar tissue that may have developed in that area, and some others as I've detailed there. So other or evolving applications of the endoscope moving forward. The totally endoscopic stapedotomy is also something not really evolving. It's something that in parts of the world now is routinely done. But the acoustic neuroma surgery and the use of the endoscope in cochlear implants is something that is really, really gaining momentum with time. I'm not going to talk about it in this talk. I was trying to stick to more conventional uses of the endoscope. But if you are interested in these kind of studies, they're really increasing in the literature as I've seen there. And I've just projected some of the studies that you may be interested to look at. And the other aspect of my talk that I want to discuss in relevance to the endoscope is about cost. The safety and the efficacy have been demonstrated with the endoscope. And the next question that surgeons ask, hospitals ask, is about health economics, especially when you introduce a new procedure, a new technology, or a new technique to perform certain operations that were previously performed using a different technique. I'll talk about this study that was done in Sydney about 2 years ago that directly compared the cost of a totally endoscopic approach versus an open approach. And what they did is that they assessed patients with an attic cholesteatoma, and they assessed them and felt if they were suitable for a totally endoscopic approach. Those patients were then subdivided into 2 groups, either with a total endoscopic ear approach or with an open approach. And as you can see here that they also detailed the associated costs for each approach that may include the surgical setup, including burrs, the anesthetic setup, as I'll talk about just now, the cost of overnight stay as well, and the average cost per minute of running an operating theater as well. So in this study and in this institution, for their endoscopic ear surgery cases, they do not intubate their patients. They use a laryngeal mask airway. And this has implications as regards to the cost for paralysis, the cost of reversal from the endotracheal tube, and the cost of the endotracheal tube itself and the gases that you're going to use. There's a total reduction in surgical time as a result of not needing a post-auricular incision or having to perform, in certain cases, a canalplasty or a mastoidectomy to access the disease. And on average, there's about an hour reduction in operating time. That equates to a mean cost of almost 2,000 Australian dollars. The other cost that they discussed was the use of burrs. So in the Australian healthcare system, they don't reuse their burrs. So using it in the endoscopic cases, they used about either no burr or just 1 burr, compared to an average of 5 burrs per open surgery case. And that obviously has cost implications to the patient and to the hospital. So if you look at the total time that's used between these two approaches, is that you'll see here that the incision, well, there's hardly any incision or soft tissue work that you're going to use with a totally endoscopic approach. So that time is gained there. You gain time with the bony, having not to do any mastoidectomy or any bony work initially. You spend a decent amount of time addressing the disease. But you see here the total amount of time that you use using a totally endoscopic approach is obviously going to be far less than a microscopic approach. And just to break down these costs, there was a helpful table that was in that study as well. And there's a considerable saving to the private hospital in this study of almost 3,000 Australian dollars per case of an articular osteoderma. And this in this study concluded that this was just an underestimation of total cost savings to that patient, in that there's a lack of a post-auricular incision and a mastoidectomy that may result in an improved quality of life moving forward, and therefore an indirect economic gain. Post-operatively, there is less nausea and pain, and therefore you do not need to use antiemetics, or you not need to use regular analgesia that also has cost bearings to that patient. And that patient is able to return to work far earlier, and therefore that also has economic implications. So what I've talked about briefly now is that, there's a cost of surgeon, an ENT surgeon versus a clinical officer. The first subdivide of that is that there's a training time involved in training an ENT surgeon in our context in Africa versus the training time involved in training a clinical officer. The numbers of clinical officers are potentially far more than the numbers of ENT surgeons on our continent. And the salary that you would pay a clinical officer would be less than an ENT surgeon that would be employed. And in our context as well, it's quite important to empower people that are involved in this task sharing approach. And if you, for example, empower somebody to perform a specific task and perform that specific task very, very well, that person really is able to do something with a lot of motivation. The second aspect of cost is the cost of equipment, and specifically with the cost of a microscope versus the cost of an endoscope. And just looking over the internet, the cost of a Carl Zeiss ENT surgery microscope is almost about 33,000 US dollars. And in this particular one that I saw, this was a used ENT microscope in Poland. And if you compare that to the cost of a rigid 0 degree 4 millimeter endoscope, you can get some for $600 up to about 2,000 US dollars. And you can see here that you save a considerable amount of money when it comes to equipment. The third aspect of cost is that, as I mentioned before, is that the widely used endoscope in ES surgery is a 0 degree 4 millimeter, 14 to 18 centimeter Hopkins rod. And that's the same endoscope that one uses in sinus surgery. So if one was thinking about setting up a unit, or if one was thinking about investing for oneself, really this is a hammer that you can use in two different ways. And that also has implications for efficiency and cost. So apart from that, there are limitations of the endoscope, and I'll discuss that now briefly, and perhaps ways to also curb those limitations. There's the obvious limitation of only having one free hand. There's a lack of true three-dimensional or binocular vision, but what has been out in the literature is that with sufficient experience, this appears to have very limited impact. There's also the limitation of hemorrhage, especially if you're using the single CCD cameras that I talked about a bit earlier on, where the scope tip gets fogs or gets smeared very, very easily. There are also cases of patients that have extreme curvatures in the external auditory meatus and the canal. And there is the theoretical risk of thermal injury from the tip of the endoscope as well. And obviously there's a learning curve, especially for surgeons that are initially taught microscopically or have been performing surgeries for decades using the microscope. How to reduce bleeding perhaps, and this is very, very relevant for those of us that are starting with endoscopic ear surgery, is that you prepare that patient very, very well with, first of all, with a local anesthesia where one injects the 4 canals of the external auditory canal. One will put some neurosurgical patties in the ear canal to encourage vasoconstriction using 1 in 1,000 epinephrine. The third thing that is advocated is position, especially if you're struggling with hemostasis, is where you put these patients in a reverse Treadlin-Bird position. They also advocate hypotensive anesthesia, and especially when we're beginning the use of suction dissectors. And the endoscopic ear surgery set that has been widely marketed and is used in many parts that use this technique is the Panetti instrument set, where most of the instruments have suction that is able to attach these instruments. How to reduce smudging and fogging. The first is just before you begin your operation is to trim your hairs. And just as you're beginning and gaining your hand-eye coordination, looking inside the ear canal, inside the middle ear, just to trim the hairs. And that allows you to get a bit of a clearer pathway as you insert your endoscope. The Tarabishi stitch as well is something that I found also quite useful in performing cases, especially when you have a very curved external auditory meatus. And you can see here the image that demonstrates that stitch. One just goes right at the end of the external auditory meatus and places a stitch and comes out in the postauricular sulcus. And then one just ties that down, sort of, pulling that and giving a bit of traction inferiorly. And really that aligns the meatus with the canal so that your pathway is unobstructed as you're using the endoscope there. One can also use anti-fog, warm water irrigations, perhaps not having the room very, very cold as well can also help with smudging and fogging. The other part of this talk that I really wanted to talk about was to demonstrate, with the use of access and the use of the endoscope, some of the lessons that have been learned when it comes to the Eustachian tube. And this is obviously an area that is in evolution, but it's something that is very, very popular currently. And I'd like to, reference, first of all, the course that I was fortunate enough to attend with Dr. Muastar Abishi in Dubai last year, where he talked about this, but also his recent talks on the insights into the Eustachian tube that he has spent a lot of time studying. So Dr. Muastar Abishi, who's really regarded as one of the fathers of endoscopic ear surgery, when he was asked in 1992 of the greatest advantage of using the endoscope in the middle ear, is that his answer at that point was to get access to areas that one cannot see. But in 2020, that there's a certain evolution of thinking, and now if you ask him in his talks, he often says now it allows him to align his surgery with the disease process, and I'll explain a bit further in relevance to the Eustachian tube. When we talk about the obstruction, or where the site of obstruction is in the Eustachian tube, this is also debatable. They are transtympanic or transnasal approaches to dilate the Eustachian tube in cases of dysfunctional obstruction of the Eustachian tube. And the transnasal approach was initially very, very popular as sinus surgery and access and skill was readily available as the endoscope and the sinus was performed regularly there. And I'm referencing this study in the next couple of slides on the site of Eustachian tube obstruction. And one of the images in this study that really shot out to me was when we look at the ventilation of the middle ear and the Eustachian tube. So you can see here, this is the nasal side of the Eustachian tube. This is the tympanic side of the Eustachian tube. This is the mastoid ASL system. And one may ask oneself, where is the narrowest portion of the Eustachian tube here? And it's quite evident to see that the tympanic side is really the part that is the narrowest or the most constricted when you look at these images and other images as well. In that same study, this was a patient that had a laryngoplasty done and reperforated some years later. And on the second look surgery to repair that perforation, there was an obvious obstruction in the tympanic side of this Eustachian tube, as demonstrated here. The second question that one is now asking about the Eustachian tube, and this again has credit to the endoscope that is allowing us to ask these questions, is whether the Eustachian tube has two parts, whether it has a bony part and a cartilage part, as has been traditionally taught. And if you look at this histological image that is also part of that study, is that this is the Eustachian tube. This is the protympanum that I showed earlier on as well. And, one can see that the protympanum extends right to the orifice of the Eustachian tube. And this is the cartilaginous portion of the Eustachian tube. So really one may ask is that where does the protympanum ends, and where does the bony Eustachian tube begin? And what has previously been done is there's just been an arbitrary line that has been placed saying that, this is where the protympanum ends and this is where the bony Eustachian tube begins. But if you look at some of these images and when you look with the endoscope in the protympanum, some of these questions are begged to being asked, because perhaps the Eustachian tube is just a saccular or a tubular structure without any bony component. So what I'm talking about here is axis, axis, and axis, especially when it comes to the use of transtympanic Eustachian tube dilatation of the Eustachian tube. Here, this is an endoscopic image of the protympanum when one looks down at what could be the potential opening of the Eustachian tube. But with axis, and one is able to approach that possible opening closer with the endoscope, one is able to see that actually that was a false passage, and the actual opening of the orifice of the Eustachian tube is a bit higher than that. So this has a bearing in the safety of what you're able to do with the endoscope, and you being able to visualize what you intend to fix. With the protympanum, this is also something that is really investigated now with the advent of the endoscope. And one of the ways in finding the true orifice, as I mentioned before, is just following the tensor tympani muscle right down there and finding the true orifice of the Eustachian tube. This is the carotid plate, that is the bony plate lying the carotid artery. There's also something that people say is a risk when one is doing a dilatation via this approach. And again, using the endoscope, there are two main formations that have now been described of the protympanum. There's the quadrangular formation of the protympanum and a triangular formation of the protympanum as illustrated here. So as I near the end of my talk here, is that I'd like to just end by, as we're approaching the future, what is going to be next. I'd like to quote a study on the use of really neat configuration of a device that fits in this case an iPhone 6 mobile phone. And as you can see here, the configuration is quite a small and a handy unit that comprises of the mobile phone, a connector, the Hopkins rod, and a light source. And in this study, as you can see here, that is being used to place in grommets. And this was successfully done with no complications. And the conclusion of this study was that configurations or equipment like this are easy to use, cost effective, and can be employed as a teaching tool as well. And it has particular value in the context that some of us come from in the developing world, where standard operating microscopes may not be available, or may be too costly to integrate in a unit. The other interesting study that I found in the future of otoendoscopy is augmented reality of the middle ear when you combine otoendoscopic images and temporal bone CT scan images. And you can see here, the first image here is that of a endoscopic image that one gets using the Hopkins rod. The second group of images are ones that are attained using a 3D reconstructed CT scan. And then with a combination, when these two sequence of images are merged, you get an augmented reality in which one is able to anticipate what one is going to get when one is performing any sort of intervention in the middle ear. And lastly, we may find ourselves in an era in which ENT surgeons may not be directly involved in diagnosis, in which patients from very remote areas may simply plug in a camera in the ear that is connected to a smartphone, and that image is then sent to surgeons, perhaps in another country or perhaps even in another continent, and a diagnosis is given and perhaps even a management plan. And then I think is the era of telemedicine and report medicine is really going to increase as we move forward. That is the end of my talk. Thanks very, very much for the opportunity once again.
Thanks, Tasia, for the great talk. We're going to ask our resident endoscopic ear surgeon here at Pritiske, Dr. Esti Meyer, if she has any comments.
Good morning. Tasia, thank you for a great talk. I think there's three issues. Laryngoplasties can be done very well with an endoscope. Some people, I've seen amazing adapters where you even put it on your laptop. But I think the moment you want to go into your middle ear, the moment you want to do ossiculoplasties, or the moment there's any cholesteatoma, then you need the best stack you can get. I've had many stacks because I work at different hospitals, and unfortunately, I think a Stort is the best. If you want to do cholesteatoma surgery, you need the best definition stack you can get. Because the problem is the moment you lift everything up and it's full of blood, you lose definition. So for cholesteatoma surgery, you need the best stack you can get. If you do, let's say you do an underlay tympanoplasty, you can do lesser quality. It is very frustrating. So definitely not for beginners, because the moment there's blood, you lose definitions. But for very experienced otologists, they would be able to know exactly where the anatomy is. So I can do it on a lesser quality scope, but if it's more than a laryngoplasty, you need to be a good otologist. And if there's, because the blood is just frustrating, and then the beauty of the endoscope is just taken away. So laryngoplasty, any scope, but middle ear surgery, cholesteatoma, you need the best you can get. Now, the burning of the light source, what you just need to do, you just need to turn the light source 50% off. You can see beautifully, you can make it a little bit more, but then you don't get the burning of any tissue, because I know it's always a thing, just turn your light source off. Then the last thing, the thing with the Panetti set is, if you want to do an atticotomy for cholesteatoma, I always struggled in that superior attic. You can see what you need to do, but you just can't get there. And it's quite frustrating. You take bone away, you take bone away. And the perks of the Panetti set is those instruments are just angled the right way. They literally bend the right way. You know, where we normally take our sucker and we bend, and we take it out, we bend it again to get it there. They are just beautifully bent. So if you want to do cholesteatoma surgery and you want to go into the attic or the mastoid, those instruments are really very elegant for the corners, because now we can see down in the additors and we can see the mastoid tip, but we don't have the instruments, and that's where the perks of those instruments come in. Otherwise, you don't need special instruments. If you're going to do a straight forward any middle ear surgery and it's not cholesteatoma or is a bigger sac, any basic ear set can do it. You don't need bigger instruments. The only thing is when you worked out the cost, remember you showed the scopes and you showed the microscope, but you need to put the stack in there because that's the most expensive thing. And I think they're probably on par. But definitely for our setting, the beauty of the endoscope is teaching. Everybody can see what you're doing. The scrub nurse can see. She, for the first time, understands what is an annulus elevator. Everybody can see. The anesthetist can see when we say we can't see or there's blood or where the facial nerve is. So the beauty, I think, for me, from the endoscopic point of view, is everybody can see. And from a teaching point of view, it is just brilliant. Thank you, Nick. Over to you.
Thanks, Christy. Are there any other comments from the floor? Perhaps can I ask Zubair, do you have any comments?
Yeah, thanks, Stacey. That was a really comprehensive talk, and I think most of the things have been covered. But it's important, I think, some things to emphasize is that the endoscopic anatomy and the endoscopic approaches to the various diseases is slightly, the orientation is different to the traditional microscopic approaches. So that is why there may be a transition and a bit of difficulty felt from people who are used to using the microscope and when they're trying to convert to using the endoscope. Although one doesn't exclude the other, and very often, especially in cholesteatoma surgery, it's very valuable to use both. And then the other point that needs to be emphasized is that the added vision, even if you're using the microscope, to place an endoscope into a mastoid cavity, for example, if you're doing a canal wall up, and to examine the sinus tympani to make sure that all the cholesteatoma is invaluable. So I think that point it really needs to be emphasized. Thanks.
Thanks. Do we have any other further questions or comments? I see Kenneth is on the line. Do you have any comments or any experience?
Good morning, everybody. Tessie, thank you very much for a nice presentation. I've had opportunity to listen to Murat's Tarabichi, and it's just like mimicking Murat's enthusiasm with endoscopic surgery. Having said that, we don't have too much experience in otoendoscopy. We use it primarily for teaching, especially the medical students. But I think it is the way forward for most of us. I read Wakisa Muwafu's paper, and it's insightful. So I think it's the way forward, and we'll try to get into it. But very much appreciative of this exercise. Thank you very much.
Thanks, Kenneth. Is there any other experience around South Africa? I see Freya ENT is on the line. Could you guys perhaps comment on your experience?
I think there's a hand raised from Abdulaziz.
Okay, you can go ahead, Abdulaziz.
Hello, thank you very much. Of course, to master techniques, especially new techniques, you need to do more say courses to cadaver dissection, if you have access to that, or attend courses. But I don't know, are there enough? The more you do, even if you are an experienced surgeon, the more you do, go back to the temporal bone and dissect it and see then these new approaches with the scopes, the Italian group, what they do, and you will find that you are going into a new very wide area, and beautiful and magnificent follow for these air cells and so on, and better achievements. Are there enough courses? I mean, I don't hear much about that. So this is a big challenge, I think, similar to the frontal sinus. So it needs special courses and more courses of that. Thank you.
Okay, thanks. If there are no further questions or comments, we've actually run out of time. So we're going to close the meeting. Thanks everyone for attending, and thanks Sia for the great talk.
Thanks, Nick.